to answer your most pressing orthopedic questions.
Let's see here. So Instagram's not quite loud yet.
Yeah, I have to enable it, right?
For
Instagram.
yep, both.
Yeah. You don't have the charger?
I don't know about
I think the little bag must
oh
be
yeah,
in there.
there I am on YouTube.
I'm gonna ask out here. Like,
Okay, yeah, ask if they have a... Do you know where your laptop charger is, Peter?
It's actually connected there.
Go find one, it's fine.
So-
We'll be alive for a minute. All right, you ready? So I'm going to scour
Go ahead.
the live on Modern Orthopedics on Instagram.
Are we live on both LinkedIn and Instagram?
We are going live in a few seconds. We're live.
All right.
Instagram.
Okay.
We're live on Instagram.
We are Instagram live. We're live on LinkedIn too.
Yep.
All right. Well, that's it. Thank you very much. So,
You're famous.
Welcome to the debut of the Modern Orthopedics AMA. I'm Dr. Peter DeNoble, orthopedic surgeon, and I am actually very pleased that we are bringing this to you live today. This will be sort of the first of hopefully an ongoing series of Ask Me Anything questions. I've got my assistant Cynthia here helping me out with some technical stuff and questions and things. So if you are tuning in and have any questions pertaining to orthopedics or other such issues or other general questions you want to ask me, I will be happy to answer questions. So, and thank you for, if you are out there, being a part of this first foray, and bear with us as we roll through this. I think it'll be great. So, without further ado, we do have some questions that we kind of I feel like are kind of almost like universal questions, especially with patients that come into the office. There's a lot of fears out there, a lot of common thoughts or misconceptions even related to cortisone, injections in general. I feel like a lot of patients have had prior experience with, like, negative experiences with injections, and I do feel like by the time they're done with at least my injections, they're very pleasantly underwhelmed with how disruptive or painful they are. So that's one thing we can get into related to not only the injection process, but cortisone and stuff like that. But I will, I'll turn it over to you, Cynthia, and you can kind of, if there are any questions, you can field them, or we can start on some of the stuff that we talked about before.
So no questions yet, but we're monitoring. But here's a really great question that comes up in general.
Yeah.
Is it true that cortisone shots are a cure-all for joint pain?
Okay, is it true that cortisone shots are a cure-all for joint pain? Well, cortisone, first of all, I think we have to understand what cortisone is. So cortisone is a corticosteroid. Our body actually produces corticosteroids naturally through our adrenal glands. And we have certain levels. Maybe you've heard of cortisol. And certainly when we get stressed out or we don't get good sleep, our cortisol levels go up, and it actually makes us kind of temporarily feel kind of good. But generally over the course of time, it can cause chronic stress and just sort of is not good for our bodies, right? So cortisone is in sort of the same vein. It's sort of in the same vein, in a sense that it can be short term. It can make us feel good. It can sometimes get us past pain in a joint or in a ligament or something. But long term, the more we learn about cortisone, even as we study it over many, many decades now, we're starting to learn a lot more about the negative side effects of cortisone. So with respect to how I approach cortisone, it's sort of selective. Each problem has a different kind of runway a different spiel, I would say, as far as whether I recommend it. And I think as we get into a more, as we get into like, as our science develops, I should say, we are finding better alternatives to cortisone. Now, look, I think the common things that people use cortisone for are things like knee arthritis, shoulder pain, shoulder impingement, shoulder rotator cuff tears, shoulder arthritis, other such things like that. Let me just break it down simply. Here are like the top 3 things that I use cortisone for, that I freely use it for in a limited way. And I never do like multiple tons of cortisone injections because at some point it has a diminishing return. But I would say my top 3 are probably carpal tunnel injections. I think that it's a good, for people with early carpal tunnel syndrome symptoms, mild symptoms, let's say, that have been going on for a few months or even a year. You can feel things, but it just hurts at nighttime or when you drive in a car. That's a great opportunity to consider a cortisone injection. It might actually cure you. Sometimes it's a temporary relief, but it also helps diagnostically to understand, okay, I gave you cortisone injection, it got better. Even if it comes back, we know exactly what's going on then. And I think that's a really good application of cortisone. And I wouldn't do more than, say, maybe a second one. If it comes back a second, if the symptoms come back a second time, I'll usually start, talking to you about releasing the carpal tunnel, which is a little procedure that's more permanent. Okay, so the second thing I would use cortisone for pretty, routinely is frozen shoulder. So frozen shoulder, or otherwise known as like adhesive capsulitis, like where you develop a stiff shoulder. More common in diabetics, but it happens with a lot of females in their 40s but also men. And it can just happen out of the blue. There's no rhyme or reason. Sometimes it's related to trauma, but other times it's not. And it's painful. Your shoulder's stiff. You can't quite reach back, or sometimes like reaching for the seatbelt, it hurts. It's restricted. So a lot of patients will come in for the first time with a lot of pain, a lot of stiffness, and that's a good time to consider not only therapy but cortisone. Cortisone in this case. What's happening in adhesive capsulitis, because we have so much motion on our shoulder, there's like tons of range, right? You can get all over the place with your shoulder normally. But when you get stiffness, when you have adhesive capsulitis, the capsule is like the lining around your joint. And the pathology here is that like the capsule gets tight. You can imagine if the capsule around your shoulder is tight, now all of a sudden it doesn't stretch the way it needs to stretch. It gets thickened, it can get, whenever I operate on these, I look in there and it's really red, inflamed. And so cortisone's a good like one-stop kind of like hit it potently with like an anti-inflammatory. And then at the same time, you get this sort of 2 to 3 week kind of like holiday window where it feels better, inflammation's down. I want to make sure my patients are in therapy, because we use that holiday or that like feeling better zone to stretch it out. And once you get through that period of time and you're able to stretch it out with therapy, that's when you come back at 4 or 5 weeks and you're a whole lot better. And sometimes you need a little more therapy, but you're past the major course. Now, adhesive capsulitis sometimes does get better on its own, but the arc is long. It's like a thawing out period that can happen over a year or even 2 years. It's a long time. So cortisone will kind of shortcut that. And I think that's a good application of cortisone. And so the only caveat with that is cortisone without therapy is a bad idea, because you'll feel good, you won't necessarily go through the motions, won't stretch it out, and then it'll wear off, and about 4 weeks later you're stuck again and it hurts again. So I don't want to keep giving you cortisone because of that detrimental effect it can have on your tissues, your rotator cuff, stuff like that. So that's my approach, and that's where I like using cortisone also. And number 3, good use of cortisone. I would say basal joint arthritis is another common one that I use it for, and that's like the thumb base. Very common. It's the most common arthritis in the thumb. I think it's a good first step if you've got some degenerative wear in your thumb. It's super dysfunctional. I might change my answer maybe like a year from now. I'm starting to do some more regenerative stuff with Shockwave in our office. PRP I've used, platelet-rich plasma, where we use your own growth factors and inject them into the joint. That's more of a regenerative kind of approach to arthritis and also some types of like ligament issues and stuff like that, that, we just need to stimulate your own healing. And, what better than to restore your natural healing powers where it's not quite getting there. And so some of the stuff that we've been doing more recently with respect to focal shockwave, pulse electromagnetic field, high-powered EM fields, and also using platelet-rich plasma. And there's some other stuff, talk about stem cells, a lot of times that's sort of thrown in there. Really the only autogenous stem cells that are FDA approved in this country are adipose-derived and bone marrow, aspirate concentrate, and like BMAC. And I don't do those as much, but they're more expensive, the kits are more expensive, the process is more invasive. We've really focused on the shockwave and pulse electromagnetic field and PRP in our practice, and we've had a lot of great success with it. So I'm really kind of getting very excited, not only for the patients that have helped, but actually to start getting some data and to start to look into, even with some case series publications on this, because it's very, 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 very impactful. Calcific tendonitis is another thing, we can talk about that. I want to just quickly mention about cortisone, just to continue to expound on it, but 3 things that I wouldn't inject with cortisone, because that's something that I see a lot of patients who come to me, whether it's a second opinion or they've seen another doctor in the past and now it's back and they're sitting in my office. I don't like giving cortisone for tennis elbow, even though it may make you feel better. It's sort of, maybe still considered quote unquote like the gold standard, or even, I don't even say the gold standard anymore. I think it's getting away from that, but it's certainly one of the most common things that like you might have a doctor offer you. And in the vein of understanding that cortisone isn't going to heal you, it's going to make you feel better temporarily, likely it will put your tissues at a disadvantage long-term to heal. And that's what my concern is. So I always I counsel my tennis elbow patients, or lateral epicondylitis. It's like that pain on the outside of your elbow and you kind of grasp things and stuff. Very common. That's also, by the way, something that'll get better many times over the course of a long time, like a year or so. So a lot of patients are like, they don't want to deal with that for that long. So they come to me or one of our docs for consultation about this. I tell people they can use bracing, straps, and one of the most effective things is one of the regenerative options that we recently talked about, which was shockwave. It's been really, really effective for my patients. I think the ones I've treated so far, they've all, I think, either completely gotten better or substantially improved thus far. And we've just been doing shockwave over the past year. It's been around for decades in Europe. And it's these like focused impulses that go in and stimulate the healing. So it's actually, again, it's stimulating a healing process as opposed to just masking the pain and probably putting the tissues at a disadvantage from healing. So tennis elbow is generally a no-no for me. It might actually make it more likely that you need surgery, so I try to avoid that if you can, generally, it's my counsel on that. Other thing is rotator cuff tendonitis, because a lot of people have shoulder problems, shoulder pain with overhead motion, stuff like that. Just from wear and tear, non-traumatic necessarily. And, it's very important to get your body to heal when you can. And one of the most common things you get, some people have the understanding, or generally it's understood out there, that there's a bone spur in your shoulder, or you have bursitis, but generally what the pain generator is in the shoulder tends to be the rotator cuff and like a degradation of the tendon. So when the tendon quality gets a little less normal, and whether it's overuse or just like heavy use or something, or maybe it's like you help the neighbor move a couch on a Saturday, and by Tuesday or Wednesday the following week you're feeling it every time you elevate your arm, and sometimes that doesn't go away, and so you may have strained the fibers of the rotator cuff. And sometimes, on a careful exam, I'll kind of examine and find out, are you tend to run at the rotator cuff fibers? If that's the case, if we go through some therapy and if we get an MRI, we find that it's just not getting better. In between therapy not working and surgery, which is obviously a much bigger deal, we found a really good opportunity for the shockwave there. I keep mentioning shockwave, but it's so important that you consider, what the application of these sort of interventions are. Cortisone is often offered to patients in this situation. And while it will decrease inflammation, it'll potentially compromise your tissues in a way that they, not only are they like kind of not healing because the blood supply is not great, but it can kind of just weaken them. And so now you feel better for a few weeks or a few days or maybe even a month, but now those tissues might be compromised. So it's not wrong, but it may not be the holistic approach that can get you as better as you can get for the long term. So I've been, for my patients in that situation, if they want to avoid surgery and they want to get better without it, most assuredly, I am offering them the option of shockwave treatments in those situations where there's not a discrete tendon tear away from the bone, but the tendon quality might be compromised a little bit. And then cortisone, if they're really kind of pushing it, the weird thing, and this is why, this is where I can start ranting about our healthcare system in this country, but guess what? Cortisone is fully covered by your insurance company. I don't recommend it. I think in a lot of cases, it's not regenerative, it's not restorative. However, they will not cover shockwave, PRP, or PEMF. So you almost have to pay to do the right thing. It's ridiculous. It's upside down, and it's the system we live in. So just to throw that out there. That's really the only downside, to be quite honest with you. And we try to price it very reasonably, attainably. I know obviously costs are a big factor for everyone these days. So we offer it and try to be reasonable about it. So that's a long answer, but
That's good.
yeah. I'm trying to think other things that I wouldn't inject with cortisone. I will say one of the common things that people do, they do get cortisone injections for is knee arthritis, right? Very common knee arthritis, super common. And look, arthritis tends to respond best to motion, use, exercise, and weight loss. These are like the mainstays. So if you're kind of intervening in that way, often things will get better. Probably one of the more effective things you can do as an alternative to cortisone, which certainly will make you feel better, again, temporarily, but may compromise your cartilage, which is already compromised, and may kind of put you on the fast track to a knee replacement, is things like PRP, platelet-rich plasma. So that's like, instead of injecting cortisone, you inject concentrations of your own growth factors. And so that has been shown, probably the most literature on PRP is in the knee because it's so common. And the literature's pretty good. There's a lot of good randomized trials. That the downside of those trials tend to be there's a lot of variables that kind of aren't consistent over the many studies. So some studies will show it has no effect, but many have shown a net positive effect. So I think the paradigm is shifting in that direction. So we will offer that to our patients who are looking for that to really truly stave off, or maybe kind of move down the road the need for a knee replacement and try to avoid a knee replacement. There's also gel injections, which a lot of people are familiar with. It's interesting, the data on that tends to show that it's not like that impactful, but we, as orthopedic surgeons, look in our own eyes, our patients do really well. Is it a placebo? Is it doing something? It's very interesting when we look at that data. It kind of confuses insurance companies. Should they cover it? Is Medicare going to cover it? So, but it is covered. Usually you have to fail cortisone, which in my mind doesn't make any sense because, again, cortisone is, potentially degrading whatever cartilage you have left. It after a month or two, the pain comes back. So, again, my feeling, if it was my knee, I would inject it with PRP. Or my friends or family, I'm recommending PRP. But again, that's an individual decision. So, again, long answer, but wanted to just mention that because knee arthritis is a big topic.
I have another question. Does a torn ACL always need surgery?
Torn ACL. The short answer is no. Okay. I think we're all kind of very familiar with whether it's, our kids in sports, professional athletes that we watch tearing their ACLs. Generally speaking, after you tear your ACL is, first of all, what is it? It's one of the cruciate ligaments, so it's the anterior cruciate ligament. There's different ligaments around your knee, right? And inside your knee, there's the ACL and the PCL. The ACL kind of comes in from this angle, so it kind of goes like this, and it stabilizes your knee kind of front to back and a little bit of rotation as well, like a rotational stability. When you blow it out, in many cases, patients will have almost this feeling of your knee sliding around, kind of almost like giving way when they walk or run. And so in those cases, especially if they're an athlete and they're having these instability kind of events, and on exam we can tell, how unstable these knees are. Those typically are ones that would probably benefit from either reconstruction or repair, depending on the pattern. There are instances when people injure their ACL, partially tear their ACL, or even completely tear it, and that the exam is stable, where there doesn't seem to be kind of a net added instability going on. In those cases, sometimes patients, or maybe if they're not athletic, or they're not they're stable enough and they're not looking to get back to a cutting sport or something like that, they can potentially rehab them. So it's sort of a nuanced, individual, case-by-case scenario. So that's the ACL spiel on that. So interestingly, one of the topics that is, I think, maybe understudied. I haven't looked at the literature lately, but one of the thoughts is that the incidence of ACL is definitely, seems like it's going up, and a lot of the question is whether it's caused by turf fields. We saw always play on grass, mud and grass, and it was dirtier and stuff like that. Now it's nice and clean, but those turf fields don't quite give the same way normal natural grass gives way. So, is that happening? It seems like maybe yes, at least, but we'll see.
We have a fun one that you might like. What has been one of the weirdest injuries you've treated?
Is that like your question, Cynthia? Or is that
It's a little curiosity on my
Okay.
end, perhaps.
The weirdest, probably. I mean, I will say that the weird stuff comes in on call at the big trauma centers, right? So when I was doing a little bit more of that stuff, over at St. Joe's and Patterson and stuff like that, you get a lot of industrial roller injuries. I'll say still what takes the cake is the patient who she got her hand caught in a dryer, like an industrial dryer, and it kind of went. It didn't have a guard on it, so she went to clean. I don't know what she was doing, to be honest. And she was working there, and she put her hand kind of in, and it got caught, and then it basically cooked her palm, and it stripped the skin out. Well, you asked, right? So, this is the weirdest thing. And it degloved the back of her hand. So on one side, it looked like you could see all her tendons and stuff. On the other side, it literally looked like her hand had been cooked in the surface of the oven, and it was kind of in the arc of the dryer, and just from the hot dryer, just cooking. It was really bad. So unfortunately, she ended up losing her arm at this level. So tried to debride it and save as much as we could, but when she was down to the palm, and we were like, all right, at that point you're going to be better off, with a prosthetic or having something that's trans forearm amputation. So we actually did nerve transfers in that case, so she could operate a prosthesis, a myoelectric prosthesis, where the muscles that I transfer nerves into, she can train herself to work a prosthetic. So we did that. But anyway, that was a wild one. I don't know if I'll ever see that one again.
That's crazy. Can you ever really go back to a normal life after joint replacement surgery?
Again, this is what patients would say, can I go back to work? What do you do for work? Right? So what is normal? What's the definition of normal? Normal, if normal is a really high-end, I don't know, you name it. Let's say it's I I don't even know. I'm trying to think of something. If you get like a shoulder replacement, right? There are going to be some thoughts that there could be some limitations. That being said, these days, our joint replacement technologies have gotten pretty good. Have demonstrated durability. Like metal on polyethylene, and those last. If they're well done by a skilled surgeon, if we're talking about like a shoulder, those you can pretty much get back to a lot of things. Sport, a lot of different things. There's some younger patients who get arthritis early. They may have developed it for whatever reason, genetically, or they just had trauma to their shoulders. So we'll do shoulder replacements on younger patients, and those do well. And once they've healed the cuff and anything that all the soft tissues around the shoulder, generally we kind of letting those patients kind of get back to whatever they'd like. Does every single person get back to quote unquote normal or whatever they want? Maybe not. Maybe it's a little bit modified, but it kind of is case by case, and everyone's a little different. And certainly by the time you're getting to the point of a joint replacement, your life is so abnormal that regaining a lot of that is very satisfying to most patients. So that's kind of like the generic answer I would say for that one. And also it depends on what joint you're talking about. You think about joint replacements, like traditionally it was like hip and knee replacements are the most common for sure. And I've seen a lot of patients, I don't even do them anymore. I don't even do total hips, total knees anymore, but you see a lot of patients getting back, especially with total hips. Total knees is a little bit different, but I've seen a lot of active patients, so I think, maybe not like running, long distance running on a total knee, but I may be wrong with that. I'm just not seeing that population necessarily. I think it depends on the individual a lot too.
I guess this leads to that, but will you lose mobility if you have like a metal plate or a screw inserted?
Will you lose mobility? Not directly related to a metal screw or plate necessarily. So like if you break your ankle, let's say, those screws and plates are on the outside of the bone. They're not actually inside the joint. We're actually kind of using those to structurally support the joint. And once you do that, the joint should be back kind of contained, aligned, the ligaments should heal. What you might lose mobility from is just the general trauma of the soft tissues around the joint. So the idea with any kind of joint adjacent fracture or joint interarticular fracture where the break of a bone joint goes into the joint and cracks it a little bit, or where it's really way off. Our job as orthopedic surgeons is to put that joint back in like a puzzle piece. We put it back together and hold it in place for healing with plate and screws. And these things are these constructs have gotten so good from even the time when I trained, when we were kind of like bending plates and trying to like customize it ourselves from something that's somewhat generic, to now we're like, they have plates that are very specific and designed and contoured to very specific spots on different parts of your bone, your knee, your tibia, your wrist, your shoulder. So the implants have gotten so contoured and specific that they tend, the idea with that is to obviously keep it as low profile as possible, so you don't feel it, so it's out of the way, it's not hanging way off your bone, and that screws will go in and kind of be within the bone, not inside the joint, but support things and wrap things. And then usually everything gets better over the course of, and we'll tell you, and I tell this to everyone, I know this myself, I just had my hip labrum fixed, not quite a year out, but I tell patients like it takes a year, almost no matter what. If you have like a scar tissue, just takes about a year or so to like be at almost like a really mature state. So when it comes to the range of motion and how your joint feels, you'll feel it like when the weather changes. It's just so it's so sensitive to those barometric changes scar tissue is, and so you'll feel it. And usually by like a year or more is like when you start to be like, yeah, I have days where I just forgot that I even had surgery. It just feels normal, especially with joint fractures and stuff like that. That's really what I generally will advise my patients on, is that you'll get better pretty quickly once the bone's healed, but there's more than that. It's more than just bone healing. There's a lot of tissue and ligamentous healing that have to go through this process of like scarring in and getting tight and then loosening up and then kind of getting to a steady state. So the short answer is plates and screws should not inhibit motion, but they are part of a process of a serious injury that probably will leave you with maybe some deficits. Some people get their motion back completely, others get most of their motion back. Some get very stiff and we have to go through a longer process, and sometimes that's just individual dependent. It's just the way you scar. It's sort of no way to predict that. The same way some people like keloid with their scars, and some people have perfect, beautiful scars. They're like, oh my God, so beautiful. I'm like, that's just you. I'll give you all the credit for that. So that's the same when it comes to like internal scarring. So.
You mentioned this already, but it's a pretty cool topic. But what are the newer treatments available now for joint pain?
Newer treatments for joint pain. All right, so I think all joint pain is like, first of all, it's so disruptive to our lives, right? So life is good until you have joint pain, and then then it really kind of becomes a bigger problem. Now you're focused on this joint every time you walk, or every time you reach or grab or twist or whatever it is, and so it's so important to kind of like not ignore it if it's going on for a little while and get it evaluated. Now, I'm a surgeon, but like my job with my patients is to get them better without surgery. And so in that realm, we talked about cortisone and some of the things that where it's good, and other times when it's not so great and it may not be the best option. Therapy is plays a huge role a lot of times. And the question, obviously, before we even get into treatments, is sort of diagnosis. And I think the role that I play in the vast majority of my patients is just getting an accurate diagnosis. I think, this gets into a bigger topic about quality these days and understanding and being a skilled diagnostician. There's lots of non-surgeons and even non-doctors these days who are out there treating patients. And some are good, but some don't have as much experience as, let's say, an orthopedic surgeon has, and a skilled orthopedic surgeon. I think it's really important to make sure we seek out, to the best of our abilities, what appears to be the most skilled and experienced surgeon or medical professional to evaluate you, because getting 80% of the time you probably have something basic and straightforward, but there's always like that 20% that are a little bit less direct, and it takes like a really like skilled, experienced physician surgeon really, people that operate on these things, that know the inside, know the anatomy in and out, and really that allows us to be better diagnosticians, because we know where it's hurting, what we push on, and different experience over time. And so sometimes when you're getting treated by mid-level providers and stuff, they just haven't operated, they haven't seen that, they don't have necessarily the experience. And I'm not saying it's wrong, but it might delay diagnosis. So at least in our practice right now, we use mid-level practitioners like for surgical assisting and helping us with patients and various things like that. But we as the surgeons see all of our patients at the outset. We establish diagnosis, we establish a treatment, and we use therapy a lot. Like I would say most patients who don't have like an immediate, like a fracture or something that's way out of place and needs to be put back together, we're using therapists a lot, and that can be in conjunction with shockwave if it's appropriate. But therapy is really, really helpful. I think generally our patients do well, with when they have a great therapist to accompany them through the process. But again, it all depends on the diagnosis. So, getting that accurate diagnosis early is going to get you to the end the quickest. And I guess that's my spiel on that.
do you pick the right orthopedic surgeon?
Good question. There's no right answer, but there are some general tips I would recommend. And I only say, because I don't know what this, so I'm on the inside of that box, right? So I can just tell you what I would do if I was looking for, like, I don't know, the best ENT surgeon or the best neurologist or something like that. Someone maybe I don't know, and that maybe is so far out of my scope of things that I don't know who that is. And I personally am privileged to know a lot of doctors, so I'll start going that out. And if you don't know a doctor, or you might start asking friends who they have had good experiences with. It's very hard. So I think one thing is you want to like go to someone who is giving you a reference. I think you need to cross-reference that with maybe some online reviews. No, online reviews aren't always always accurate, but I think you want to get a theme, get a consistent through line on like Google. Because I think patients these days tend to, spend time being thoughtful at times about, what their experience was like with a good doctor, which is sadly becoming less and less common. It's just healthcare is changing so much. So I think that if you see a doctor with good reviews, not only just 5 stars consistently, but also like commentary that is consistent, that looks like, okay, everyone's having kind of a very similar experience there. This is someone we should try. Maybe someone knows that doctor or something like that. Like the hacks, like meaning I say hack in like a way to like the way to kind of like engineer a trying to get to a good doctor. Is sometimes if like a nurse at the hospital or an OR nurse, they'll kind of know like maybe a little bit more of the inside baseball on like who's kind of considered maybe the better doctor or something like that. So that's another thought, or like a rep, someone who's in the operating room watching these doctors operate, knows kind of who's efficient, who's doing good work, they're looking at the X-rays this is like an orthopedic surgeon. So I think that like all those are like angles that I would take if I don't know an orthopedic surgeon, and I'm kind of trying to get an angle of like who's the best for me. I think the Facebook groups are always interesting. Everyone has their own favorites and loyalty to different doctors, but I think that a lot of like moms and stuff will reference that, and that's a good starting point. But I think cross-referencing. Also check out like I think the websites and try to see what the doctor is putting out there. Do they have any videos, or can I get a sense of who they are before you go in and like I don't really like the doctor's personality. Like I didn't really know because I just saw their headshot from like 10 years ago. So it's kind of, fortunately these days we can kind of like get little windows into who they are, where they practice, what it's going to feel like, so that you can be like, yeah, I think that's going to be a good experience for me, and let's give it a try. You never quite know, but you can get pretty close.
So last one, what would you say is your advice for anyone struggling with joint-related pain?
Anyone struggling with joint-related pain? Well, if they're struggling with it, that probably means, well, I don't know. If they're struggling with it and have not sought an evaluation by a skilled surgeon, then I would get an evaluation. I think I don't want to speak for all surgeons. I only know how I approach my patients. I would generally think that most surgeons, and most of them, will tend to take a conservative approach. Not all of them, but we do. And I think that generally the generality of surgeons do as well. They do the right thing. So I think that the fear of needing an operation, and even if you go to a surgeon and they say you need an operation, you're entitled to a second opinion. So, come see us at Modern if that's the case. But I think that seeing a surgeon who is very comfortable with the anatomy, very comfortable with getting a diagnosis, getting an MRI, getting imaging studies, doing a careful and thorough physical exam is important, because you want to just make sure that you know, it's either nothing to worry about, need some therapy, no problem. There's no need to like suffer when you can kind of get some more insight. And you know, I would generally say the rule of thumb is like, look, if you pain can sometimes go through arcs. You know, sometimes it's like 2 to 3 weeks, and then it kind of starts to get better. If it starts getting better, maybe you just let it see what happens. But if you're kind of like 3 to 4 weeks into something and it's still pretty intense, it's probably worth checking out. You know, and yeah, that would be kind of my general thought. We were very good here, at least, at getting patients in pretty quickly. So, you know, and getting an evaluation. I mean, worst case scenario is also the best case scenario, which is that, oh, I feel like I kind of wasted my time, and nothing's much wrong. And so I think that's a reasonable thought. You could just like kind of let it go, but sometimes there are certain circumstances where you want to know about things earlier. You know, various fractures that are subtle that you thought it's this wrist sprain, or you thought it's a finger jam and it's actually like a more serious fracture. So sometimes that's an issue where you want an x-ray like quickly. That's more of a traumatic scenario. So I've seen both scenarios where I've fortunately caught them early, or the patient came in to me 6 months later and said, hey, what's going on here? And it was like, ooh, that was a fracture all along. And you know, so those sometimes need, you know, more complex surgeries. So anyway, that's my answer on that.
Yeah, we can wrap it up.
All right, that's a wrap. Thank you very much. Thank you for joining us, and yeah, look forward to doing this again. Thanks, guys.